Good afternoon. Welcome to our last virtual support group of 2025. My name is Jillian Schultz. I'm the program director for the Parkinson Association of the Carolinas, and we're happy to have you here today. And I apologize for any confusion there was with the time of today's session. We are actually going to be moving our virtual support groups to 12 o'clock noon starting in January. So this is kind of an adjustment to get there. This was a very requested topic from the community when I went out to support groups and other places to talk with people with Parkinson's disease and their care partners. So I'm very excited to be able to have Dr. Fleming here today, who is going to talk to us about sleep and Parkinson's disease. So if you don't know Dr. Fleming, he specializes in treating movement disorders like Parkinson's disease, tremors, ataxia, dystonia, chorea, if I said that right, myoclonus, and tics. He completed his residency at Virginia Commonwealth University and a fellowship in movement disorders at the University of Miami, and he's been with Atrium Health since 2020. So I'm going to go ahead and turn it over to you, Dr. Fleming.
All right. Thank you so much. I'm going to share my screen. Is that working for you?
Yes.
Okay, perfect. Well, thank you so much for having me. I'm looking at the joined list here. I see a few patients that are mine, but for those that don't know me, hello. And I think we're talking about a very important topic today because sleep disorders are extremely common. So especially in Parkinson's disease. So about 40% of people with Parkinson's are having at least one type of sleep disorder, and I think that they're generally underreported. This could be for a variety of reasons. Sometimes there's a lack of belief that there are good treatments for them. Some people are unaware that the symptoms actually associated with their Parkinson's disease. And other people might not even recognize that their sleep disorder is causing any problems. So before we get into the sleep disorders, you got to understand the normal sleep cycle. So we all have this sleep architecture. And this changes over the course of a life. As we age, the architecture becomes different. But in general, we have different stages of sleep that you all may know about, and you go through about 3 to 5 cycles per night, lasting about 90 minutes each. And they go from stage 1 to stage 3, and then to stage 4, which is rapid eye movement or REM sleep. And this stage 1 typically only lasts a few minutes. It's really just a transition into stage 2. You normally don't really see stage 1 again unless you're woken up. But stage 2 is when your heart rate and your breathing starts slowing down. You spend about 50% of your night in stage 2. And then stage 3 is considered a deeper sleep. It's used more for body recovery, for growth. Most of the time spent in this is in the first half of the night. And then REM sleep, that's where you are dreaming. It's good for cognitive function like memory and learning. About 25% of the night is spent in REM sleep, and most of that is occurring in the latter stages, so early morning hours. And in REM sleep, you really should be atonic, meaning you don't have the capacity to move around, that you're essentially paralyzed. But as you guys probably all know, and as we'll talk about in Parkinson's disease, that mechanism can get disrupted. So it's important to move through these stages in a healthy way. And what it generally looks like, if you hook people up to machines in a sleep study and look at their brain waves, you can tell what stage of sleep they're in. And this is graphed out for a normal, healthy sleep architecture. So you'll see stage W, that's wakefulness. Stage R is REM sleep. And then stage 1, 2, and 3. And you'll notice just in REM sleep, these bold areas, most of them are occurring in the late night, early morning hours. And you'll see a few arousals, maybe one here at this 3 and 6 hour mark. And those are extremely brief. Most people, it happens, but they go right back into stage 1 or stage 2, and they don't even know that they woke up. Now, in Parkinson's, this can be when people's tremor, if they have tremor predominance, they can perceive this as waking them up. But really, they naturally hit stage W or wakefulness, and that tremor then kind of brought them into consciousness. So This healthy sleep architecture, when you get really disrupted, it can start to slow your thinking down. It's associated with a reduced attention span. Memory can start declining. Uh, Decision making can become poor. People can have just a lack of energy. They can have mood changes like heightened stress, anxiety, more irritability, just less of an ability to cope with whatever stressors are going on in their life. And you'll see this is a polysomnogram of somebody that has very poor sleep architecture. So you see a lot of nocturnal awakenings, not much REM sleep, and not much time spent in the deeper stage 3 sleep. And so it's hard if you have a lot of awakenings to get back into that deep stage 3 sleep. And so, all that to be said, what are some of the problems that can occur with Parkinson's disease? So, insomnia is a big one, excessive daytime sleepiness, sleep apnea, restless leg syndrome, and REM behavioral disorder. So, for insomnia, this is defined as a persistent difficulty to get to sleep and stay asleep. And this is the most common sleep disorder in Parkinson's disease. It hits about 30 to 80% of people. And this can cause a lot of sleep fragmentation. People can be awakening very frequently throughout the night. And many people may not have a difficulty falling asleep, but they wake up really early. They wake up at 4 a.m., 3 a.m., and they have difficulty falling back asleep. And this has a strong association with worsening mood like depression. And the longer Parkinson's is in the body, the more apt somebody is to develop insomnia. And so part of the treatment strategy is to improve sleep hygiene. And sleep hygiene is just related to behaviors prior to sleep that you can use to really make sure that you're giving yourself the best chance to get a good night's sleep. And part of that is establishing a normal bedtime and a normal wake time. Now, some neurologists will say it doesn't matter when you go to bed, just go to bed when you're tired, but just make sure that you wake up at the same time every day. And this can help your body start to regulate in more of a normal cycle. And that cycle can change. So, what you were doing 20 years ago with your sleep wake cycle, that's probably different now. And so, it's good to listen to your body and know what is abnormal and what's normal. Now, if your body's waking up at 3 a.m., that's not a normal waking up time. But if it's 6 a.m. and you're used to waking up at 8 a.m. your whole life, well, 6 a.m. is probably going to be your new norm. And so it's good to just sort of set an alarm then, and then do your best to, as number two says, allow yourself to take a nap if you're tired throughout the day, but not too much. I mean, there's a limited benefit there where you can start to really affect your nocturnal sleep if you're napping way too long or too late in the day. So I generally tell patients to try to reduce your nap time to no more than 30 minutes and earlier than 3 p.m. And if you're drinking caffeine, if you're drinking alcohol, you really got to avoid alcohol later at night. That can really affect the quality. It can really disrupt that sleep architecture. Too much caffeine use. The half-life of caffeine is about 6 hours. So you've got to think the half-life means that in 6 hours, half of that caffeine that you drank is still in your system. So if you're drinking caffeine at 5 p.m., half of it's still in your system at 11 p.m. when you're trying to fall asleep. And so knowing that, to back off on caffeine in the afternoons. Um, Working out. So exercise is important for sleep, but only if you do it really in the morning or the early afternoon. It's kind of like naps. So if you work out too late in the evening, your body's gonna have a difficult time starting to slow down and wanting to fall asleep. You also want to make sure that your bedroom is just a sanctuary for sleep. It is cool, it is comfortable, it is dark. There's no TV, there's no bright lights from the TV, there's no noise, and it's really just used for sleep. If you're using it to watch TV, your body's going to start conditioning itself to just associate bed with TV or bed with some activity rather than just sleep. So it's good to just have that conditioned response where bed is sleep. If you do all that and you're still having a lot of insomnia, It's important to rule out other causes. It may not just be you have Parkinson's and therefore you have insomnia, but if you're having a lot of people wake up a lot because their bladder is overactive. Parkinson can cause that too. It can cause overactive bladder, especially in those people that have a lot of tremor. The bladder can start to kind of spasm and give that sensation of needing to wake up frequently to urinate, even though not much may come out. But it's important to regulate how much fluid intake before bed. It's not you're not drinking a lot of fluid and then trying to fall asleep because your body's probably going to wake you up a lot to urinate throughout the night. There's bladder anti-spasm medications too that can be used to reduce frequent nocturnal awakenings for bladder stuff. But some people, if they're not medicated on levodopa or any other movement related medications overnight, sometimes it's lack of mobility that can wake people up. They can, if they're having off symptoms when they're asleep, it can really affect their ability to roll around in the bed that we naturally do to just get comfortable. And that can just wake people up. And they may not know why they wake up, but it's actually because they're just not shifting around as they typically were to get comfortable. And so maybe changing the dosing of their medication or their medication regimen is the solution there. Cramping can wake people up, especially in the legs with Parkinson's disease. Sometimes it responds to medications. Other times it's going to be more conservative therapy. If there's a lot of pain associated with other things going on, that can affect sleep as well. But it's important to not use over-the-counter sleep aids. A lot of them contain what are called anticholinergic medications or something called diphenhydramine, Benadryl. This is a substance that can really become habit forming. Your body can just start adjusting to it and requiring more and more. Those anticholinergic drugs are also associated with higher incidence of cognitive impairment and dementia, so you don't want to use those long term. Now, if you take them, you'll probably sleep pretty well, but it's just not a good long-term solution. It's kind of like taking oxycodone for headaches. It's going to knock your headache out, but long term, you're going to habituate to it. You're going to need more and more, and you get into a really rough road if you continue using those. So we generally use melatonin or prescription sleep agents like trazodone or mirtazapine. Those are antidepressants, but they have such strong sedative properties. They're used a lot for sleep. If people need something beyond that, they may see a sleep medicine specialist who can prescribe some more specific agents that are directed just for sleep, not off-label like the mirtazapine and trazodone are. Also, getting light. So sunlight is very important, and if you are not getting a lot of sunlight, you're not getting outside, or it's starting to get dark a lot earlier, it's cloudy, it's damp and rainy and all that, you're not getting a lot of sun, your body's wakefulness is not going to be as robust as it is on a bright sunny day when you're outside for several hours. And so what's used for some people, and I think this is used more in Europe and the northern latitudes where they're not getting a lot of sunlight, are light therapy lamps. And so this provides what the sun is giving you without all the UV radiation, but it is known to really promote wakefulness. So people that just like an hour in the morning, if you're not able to get outside or you're too sedentary or you have some significant immobility, then having this as your form of sunlight can be quite useful to help promote wakefulness during the day and restorative sleep at night. But if you are still not sleeping well, you may have excessive daytime sleepiness. And this is a difficulty to remain awake and alert during the day. And so people can sort of just drift off to sleep typically this occurs with very little stimulation. So people may have just like watching TV or they're just kind of sitting there not doing anything. And then the next thing they know, their spouse notices that they fell asleep. But if they're really active and engaged, if they're talking to somebody or they're playing a game or they're out at lunch or at a community event or an exercise class, they typically aren't going to fall asleep. They may feel sluggish, but but usually it's a lack of engagement that makes people predisposed to needing to fall asleep during the day. And that can be a consequence of the insomnia, but it can also occur in people with, if this is the last bullet point there, people that are on dopamine agonists. So pramipexole, ropinirole, or the Nupro patch. Some of you may be on one of those. These carry a fairly high incidence of sleep attacks. You can just fall asleep without warning. Um, for a couple of people that have gotten them into difficulty with driving, they fall asleep at the wheel, like at a red light. Um, so it's important to know if you're on anything that's going to contribute to sleep attacks during the day. Um, but being older, having a more advanced stage of Parkinson's disease and other sleep disorders are going to increase your incidence of having excessive daytime sleepiness. So part of the treatment is to identify any reversible causes that may be present. And so looking over the medication list with your doctor, identifying any other comorbid sleep disorder that may be occurring that's causing this excessive sleepiness. So light therapy is one that we talked about, but caffeine can be useful sometimes for those that aren't drinking it. Modafinil is a stimulant. I've rarely prescribed this. There's some limited data on this as far as using it for the general fatigue that people can feel with their Parkinson's. And sometimes people can have this just overwhelming fatigue. It's like their biggest symptom, but yet they can tell me they sleep pretty well. And so sometimes we try modafinil in those cases, but I just unfortunately just don't find that it works too well much of the time. But sometimes if the sleep disorder or the daytime sleepiness is significant and really, really impacting someone's quality of life, I think it's worth a try because the risks are fairly low with the stimulant. So sleep apnea. Sleep apnea is a disrupted breathing during sleep. So there's what happens in sleep apnea with obstructive sleep apnea anyway, is you get this obstructed airway. And you can see this gray line. This indicates airflow. And so air's flowing through the nose generally when you're asleep and coming back through the nasopharynx and into the trachea and into the lungs. And what can happen if you look at the picture on the right, if you're lying, especially on your back, the nasopharynx can start to just collapse on you, the back of the tongue can, and just really obstruct that airway. And so when this happens, you can really have loud snoring. Spouses can note that the person is just not breathing sometimes. Sometimes they can have long spells where it seems like they're not breathing at all. You get 10, 20 seconds without a breath. There can be abrupt awakenings with gasping or choking. People may wake up with a headache or with an excessively dry mouth because they're mouth breathing a lot with this. And then they have other symptoms of poor sleep, which is difficulty concentrating during the day, mood changes with depression and irritability. And so it's tough to know if you have this if you live alone or you sleep alone. If a lot of patients, their spouse will indicate that they snore a lot or they stop breathing. So obesity is a major risk factor for this too, but people can have obstructive sleep apnea even without obesity. So in those patients that are of a healthy weight, you still can't just automatically rule this out. So if there are any of these symptoms that are occurring, sometimes it's good to just get this checked out with a sleep study. And so with a sleep study, the sleep neurologist or the sleep specialist will be able to know with the recordings if you're having prolonged periods of apnea, how many apneas per hour, how many awakenings per hour. You can gather a lot of data on sleep with a sleep study. So weight loss for those obese patients that are having a lot of symptoms of sleep apnea, side sleeping can be significantly beneficial because, as you noted, if you're lying on your back, gravity's just pulling everything down and obstructing that airway. But sleeping on someone's side, usually they snore a lot less frequently. Using a mouthpiece or a mouth guard can sometimes help if the symptoms are mild. But then you're looking at other therapies like, I'm sure most of you know about CPAP, continuous positive airway pressure. They make a lot of different machines for this. There's the mask, but those that are having difficulty with the mask, there's nasal pillows, and now there's even surgery that can correct some of this as well. With like the Inspire device, if you guys have heard of that. But you can imagine, I think a lot of you guys may know about behavioral disorder where people are thrashing around in their sleep, and so having a contraption like this tied to you can be very, very difficult if you're also suffering from REM behavioral disorder, because some people get twisted up in the hose, and it's just incompatible with having a CPAP device. Um, so restless leg syndrome is another common sleep disruptor in Parkinson's disease. This is an extreme urge to primarily move the legs that typically happens at night. So it's defined as an urge to move the limbs with or without sensation. So most people will say that they have some kind of creepy crawly sensation in the legs, or there's ants crawling on there, or there's a warmth or a tingling. Something just doesn't feel right. Most people say this, and that because it doesn't feel right, the only corrective mechanism is to move the legs. And that's either wiggle them around a lot in the bed, or it's standing up and walking around, or it's marching in place, it's squeezing the legs. It's Some people get so frustrated they're punching their legs because it's so irritating. And this is generally worse when someone's sitting in a tight spot, let's say an airplane or a car, but worse at night if they're kind of relaxing, they're watching TV in their living room, or if they're going to bed and they lay down, then it'll start up. But it is not an involuntary movement. It is a voluntary movement that is in response to some sort of sensation in the legs or some sort of urge that they have. Um, Associated with this is something called periodic limb movements of sleep. So this can be mistaken for restless legs. Like when someone's asleep, they may be moving around, they may be kicking their legs a lot, like they're very uncomfortable, and that can wake them up a lot. And that's kind of related to restless leg syndrome, but it's PLMS, periodic limb movements of sleep. Um, but restless leg syndrome, voluntary movement due to some type of urge or discomfort of the legs. So the first thing to do about this is to check iron stores. So there's a lab called ferritin. The normal value should be over 75 in those patients with restless leg syndrome. So sometimes people, they realize they're iron deficient because they develop this phenomenon. And when we check the ferritin levels, are extremely low, and iron completely solves their problem. But some other people they really need other medications. So medications can be carbidopa, levodopa, dopamine agonists, so similar treatments for Parkinson's. But gabapentin and Lyrica are pregabalins. I kind of view it as gabapentin's cousin. It can be very useful. And those are the only two medications, the gabapentin and the pregabalin, that do not cause augmentation. And what I mean by augmentation is the restless leg syndrome can start changing over time the longer you're on, let's say, a levodopa or dopamine agonist, where the symptoms starts to occur earlier and earlier in the day, or the symptom requires more and more medication. And so if someone comes in to me without Parkinson's disease, they just have restless leg syndrome, we do our best to try to stay away from the dopamine agents as the primary treatment of choice for these, because long term it can get them into a bind. So we really try to mitigate the symptoms with gabapentin. But really, first and foremost, you want to make sure that people don't respond to iron, and with just lifestyle modifications, because sometimes just alternating between heat and ice, just having some sensory input to the legs can really reduce somebody's urge to move their legs. We know morning exercise can really help with restless leg syndrome later in the day and in the evening. Some people will get massaging devices, or they'll have air compression devices that kind of go up their whole legs, and they'll turn it on at night when they're laying down, and the machine will squeeze their legs for them. So instead of them having to get up and move around, they're getting that sort of stimulation while they're relaxing in the bed. There's a newer device now called the Nidra device. It's an electric stimulation in some of the nerves in the legs. Um, I've yet to get any feedback from patients. I've prescribed it a few times, but it's pretty new, so I haven't heard back from them. But the data on it is promising, and so the FDA has approved it, but I don't have any personal anecdotal reports on this yet. So the final one is REM behavioral disorder. So this is a problem where people are starting to vocalize, they'll scream or yell, they'll have complex movements during REM sleep. So this is during that one stage of sleep that we talked about most commonly occurs in the early morning or very late night hours. And we refer to this as sort of like a dream reenactment, because that's typically what people are experiencing. People may wake up from a spell and know exactly what they were dreaming about and why they were moving the way they were moving in the bed. Um, but this can be from very mild. So 25% of people have with Parkinson's disease have this, and it is extremely correlated with Parkinson's. So I'll have, because in the general community, if anybody just randomly gets REM behavioral disorder, they've got about a 75% chance of developing Parkinson's within the next 10 to 11 years. And so even the sleep specialists here at Atrium, if they find somebody, if somebody comes in with this problem, they'll send them over to our movement clinic just to make sure they don't have any underlying Parkinson's disease that's actually going on that they may not even be aware of. But this is during REM sleep, there's that loss of that atonia, that paralysis that should be occurring. So people are freely able to move around, punch and fight and yell and scream and do whatever they want to do, completely out of their own consciousness. That just ends up, you can really get them into dangerous scenarios. I've had people that have fallen out of the bed and broken their arm. One person had run across the room directly into the window and broke the window with her face. And it can be quite distressing. And so some of the kind of lifestyle stuff we talk about is to just make sure the bedroom is a safe place. So if this happens and it's severe, making sure the bed is as low as it can be to the ground, making sure that nightstands are pulled away from the bed, make sure there's something soft to land on if that's going to happen. Sometimes having bed rails can be effective, though. Yesterday I had a patient who said he jumped over the bed rail to try to catch something in his dream. But as far as medications, melatonin is the first line agent, followed by clonazepam. Unfortunately, there aren't a lot of other medication options for this. There are strategies to try to utilize, like if there are any other medications on board that could be exacerbating this. So a removal of antidepressants, especially those that are hitting serotonin receptors. So this would be the serotonin reuptake inhibitors like fluoxetine, which is Prozac, citalopram, and well, there's probably 20 of them, but mirtazapine could be one of those. But also beta blockers, so stuff for the heart that can sometimes exacerbate this. So we'll try to pull those off if somebody's having significant difficulty with this, even with medications on board to try to help it. But melatonin, I usually start as far as the data, the literature shows that the starting dose for symptomatic benefit is at 6 milligrams. But I don't think melatonin comes in a 6 milligram formulation at the store. And so what I usually have people do is just purchase the 5 milligram tablets and go up by 5 milligram increments, and they can max out at 20. And it's important that if you have a bed partner, have them monitor how frequently this is happening, because it's not going to completely abolish the symptom. It's not going to go completely away. But if we can reduce the frequency of the spells and the severity of the spells, then that's a win. So it's easy to want to seek perfection, but if you do that, you're going to be escalating medications rapidly, and you're going to be at max dose with potential side effects and still have some of the symptoms of a behavioral disorder. For clonazepam, this is something that has been, some data supports the use of lower doses. Like it shows that lower doses can be more beneficial than higher doses. But if people are just not responding to the lower dose, I still escalate slowly anyway. But this can be habit forming too, so I'm very cautious with how high I go. I usually never go past 2 milligrams, but I start at like 0.25. So that is, those are the most common sleep disorders in Parkinson's disease. And so I hope that healthy sleeping is extremely vital. Like the all Parkinsonian symptoms with bad sleep get worse. I know tremor's worse, mobility's worse, the feeling of fatigue, the slowness of movement, difficulty getting up, everything with Parkinson's just gets worse if you're also chronically sleep deprived. And so it's important to talk to your doctors about your sleep. And if you're not getting adequate sleep or you're feeling tired throughout the day or one of these symptoms that we just talked about is happening to you, there's possible solutions or possible treatment options that can really help. And you may start with a healthy night's sleep, you may start experiencing a better day. And you'll notice, oh, medication seems to be working better for me during the day. And it's just my whole life just feels a little bit brighter. I have more energy. It's a little bit happier. I'm a little bit less stressed. They can make a big difference. So, and also exercise. Exercise is key to sleep. And exercise, like I said, mostly in the morning or the early afternoon is the best time to do it. But I'm happy to take any questions for those that have some. Thank you for your time today.
So there's a question in the chat. Do you think magnesium supplements are helpful?
Yes, I have. Magnesium seems to be taking off as this like miracle supplement or something in the last few months. I've been hearing a lot about it for a variety of reasons, but sleep is one of them. And so magnesium has been shown to help with like leg cramping. It's been shown to help with insomnia some as well, with constipation. So it's got a multi-use in it, but I can't guide you on the type of magnesium to take or how much to take. I also don't know. It may be worth talking to your primary care doctor to measure magnesium levels before you start as well, just to make sure you're not on the high end of normal, because you don't want to get too much. But there's a lot of different formulations of magnesium. Some are much more um, tolerated than others. Some are geared more towards they can cause a lot of diarrhea. Like so, some people use those for constipation, but for sleep, yeah, it's a fairly benign supplement or vitamin, and so I never shun anybody away from trying that as well.
So another question in the chat, if patients are on Prozac and are exhibiting REM behavioral disorder episodes,
Yeah, yeah.
would this be exasperated?
Could be.
And would you recommend stopping the Prozac?
It's a tricky situation sometimes. Like sometimes the mood disorder is more important than the movement disorder. Um, and so it kind of depends. Like there's a scale. It's like a weighted scale here. And so what's more important? Because there are a lot of alternatives to Prozac that you could potentially try, like Wellbutrin for one, that doesn't really impact REM sleep behavior disorder or restless leg syndrome. And so would you be better off with that medication than Prozac from a mood disorder, and would it help without potential exacerbations of the sleep disorder? Probably so. And I think that it's worth the conversation to whoever's prescribing your Prozac to try to wean off and maybe switch over to something different. Um, but it's a purely a case by case basis. I wouldn't. There's not like sort of a blanket recommendation for everybody, because everybody's got their own sort of battles that they're facing with their sleep and their mood, depression, anxiety, and all that. And depending on what other medications they've tried for mood too. So I can't give a clear answer there, but just know that Prozac could certainly be exacerbating the REM sleep behavior disorder or the restless leg syndrome.
Thank you. So another question in the chat, have you heard about melatonin and slowing of heart rate? Also, can you take melatonin for an extended amount of time?
You can take. I've not heard of melatonin with decreased heart rate, but yes, you can take melatonin long term. This is something our brains naturally secrete. This is what our brains use. That whenever the sun starts going down, our brain starts secreting more and more of it to sort of prime us to start going to sleep. So we're just kind of adding more into the system, kind of like dopamine, what we're doing with Parkinson's and the dopamine as well. So
So another question, do some of the medications give Parkinson's patients hallucinations?
um, I don't know. There are certainly medications for Parkinson's that cause hallucinations, especially like the dopamine agonists, propranolol, pramipexole, Nupro, amantadine. Those are highly hallucinogenic. So if you're on one of those and you're hallucinating, those are usually kind of the first line things to start weaning down on. If the hallucinations are bothersome, like if hallucinations are there but it's not really a big deal, then I wouldn't go messing with medications. But if it's substantial, if they're scary, distressing in some way, then yeah, start talking to your doctor about possibly weaning down these medications. But as far as um, the medications for some of these sleep disorder stuff, not really. Like clonazepam can make people, it can cause some confusion. And when you mix that in with like dream material, which can seep into reality in the middle of the night, yeah, I could say that it could be kind of causing some sort of psychological, psychoactive phenomenon in the middle of the night where you may start seeing dream stuff when you wake up, like in your bedroom. That lasts for a brief moment, but you flip on the lights and it kind of goes away and you're reoriented and then you can go back to sleep. But I don't view clonazepam as like hallucinogenic.
Thank you. And just off topic, but related to hallucinations, next week we have a webinar on hallucinations and delusions.
Okay.
Yep. So another question, when sleep can't be obtained despite the trazodone and other recommendations, then what?
Depends on what you're talking about. I mean, if you're going to say it doesn't respond to anything, then I can't help you. I don't know. It's just there's a limit to therapies here, so it kind of depends on exactly what medications you're on and what exactly you're suffering with. Because if you say, yeah, my sleep hygiene's perfect, I'm not on any medication that's going to worsen any of my sleep related stuff. I'm optimized with my other medication regimen. I'm not drinking caffeine at night, I'm exercising, I'm getting daylight, and everything's still bad, then it may be like if it's insomnia, it may be worth going to a sleep specialist. That because there are some medications that are FDA approved just for sleep, just to really knock you out and make you stay asleep, and that might be what needs to happen. But if the question is relating to some other sleep disorder that we talked about, I don't know. It kind of my answer would change based on which one we're talking about.
Thank you. So another question, have you read the popular book Why We Sleep by Dr. Matthew Walker? And then are there other books or educational resources that you recommend? And then it also says thank you for your presentation.
Oh yeah, thank you. No, I have not read that book. Yeah, the sleep disorders and Parkinson's disease. I'm not outside of the general um, sleep educational stuff that the Parkinson's Foundation, the PAC, and like Michael J. Fox Foundation all put out. I'm not familiar with like specific resources for sleep and Parkinson's disease, like outside of those resources that I tell people about.
Any other questions? And you can also feel free to unmute yourself or continue to type in the chat.
Yeah, we've got about 3 minutes.
All right. Well, I want to thank you, Dr. Fleming, for the presentation today.
Of
I
course.
will
Yeah.
be I will be posting this up on our YouTube channel later in the week, so you'll be able to watch it again. Or if you know anybody who wanted to be here today but wasn't able to make it, you can also have them check that out. We do have a webinar next Wednesday at 2 o'clock about hallucinations and delusions with Parkinson's disease. And then we will be taking a break for the rest of the year and we'll be back in January. We do have our first virtual support group for January scheduled. It's about freezing of gait and how to manage it. And that will be at 12 o'clock on the first Wednesday in January. So I hope to see you then. The information will be on the website soon. It's not there yet, but it'll be up soon. I hope everybody has a great rest of your afternoon. If I don't see you again this year, I hope you have a happy holidays, happy new year, and everybody have a great rest of your day.
Thank you.
Bye.